Hi all, in this video we're going to see about the regulation of renal blood flow. Now this is a very important topic, has been asked multiple times in various examinations as short essay questions. So we'll see more about this. So first I would like to give a brief introduction, otherwise those students who don't have the basics might find it difficult to answer this question. So we know that the arterial supply of the kidney is supplied by the renal artery, which is a branch of the abdominal aorta. The renal artery, once it enters through the hilum, it divides into the segmental arteries. From there, it further divides into interlobar arteries, and from there into arcuate arteries and interlobular arteries. So it is from these arcuate arteries that we have the afferent arteriole, which forms the glomerulus along with the efferent arteriole. The efferent arteriole then further breaks down into the peritubular capillaries and then drains into the arcuate vein, which in turn drain into the renal vein, and so on. Now, so basically it is this, the renal blood flow is in close relationship with the glomerular filtration. It is from this glomerular, so it is from this blood that the filtrate, glomerular filtrate is being formed. So we have to know the basic knowledge about the relationship between the renal blood flow and the glomerular filtration. So suppose this is our afferent arteriole and efferent arteriole, and at the center we have the glomerulus, and this is the Bowman's capsule. So now I said there's a relationship between the renal blood flow and the glomerular filtration. So what is that relationship? See, basically the filtrate is formed based on the pressures that is being exerted onto the filtration barrier of glomerular capillary membrane. So inside this glomerular capillaries we have the hydrostatic pressure of the glomerular capillaries, which pushes the fluid out into the Bowman space. We also have the oncotic pressure of the glomerular capillaries, which pulls the fluid into the glomerular capillaries. Similarly, for the Bowman's capsule also, Bowman space, we've got the hydrostatic pressure which pushes the fluid out from the Bowman space into the glomerular capillaries. In fact, ideally there should also be an oncotic pressure for the Bowman's capsule, but the thing is there are no proteins, hence the oncotic pressure exerted by the Bowman space is zero. So the force that helps the fluid or helps in filtration is this hydrostatic pressure, which is exerted by the glomerular capillaries. So just imagine, suppose there is a high, there is a high flow, or there is a hypertension. What will happen? There will be increased renal blood flow, right? So if there is increased renal blood flow, what will happen to this hydrostatic pressure? It is going to be increased. So there will be more glomerular filtration. Now there are various scenarios in which there might be an arteriolar constriction or dilation. So then also the glomerular filtration as well as the hydrostatic pressure might change. So we'll see what those changes are. So suppose this is our glomerulus along with the Bowman's capsule. Now suppose there is a constriction of the afferent arterioles. What happens? The renal blood flow is going to decrease because there's a block here in the inlet, right? So what will happen to the hydrostatic pressure? That is also going to decrease. So naturally the GFR is going to decrease. So if there is afferent arteriole constriction, there is going to be decreased GFR. But what if that constriction is in the efferent arteriole? So say the outflow tract is now obstructed. So what will happen? There will be a black backflow. So there will be increased hydrostatic pressure, which means there is going to be increased filtration or increased GFR. Now, so that was about constriction. What about dilation? Suppose there is an afferent arteriole or a dilatation. So how will be the blood coming in? Is going to be increased blood flow. So naturally there is going to be increased hydrostatic pressure, increased GFR. What if it was a efferent arterial dilatation? In that case, there is going to be a decreased hydrostatic pressure and decreased GFR. So this is the very basic knowledge that one should have related to renal blood flow in order to understand the regulation of renal blood flow. So now we'll move on to a topic proper, regulation of renal blood flow. So in fact, the kidney receives around 20 to 25% of the cardiac output, and it must remain stable for filtration and homeostasis. So that is why we've got three mechanisms which ensures that the renal blood flow is same. So the three mechanisms are, first one is autoregulation, second is neural control, and third is hormonal and paracrine control. So we'll see each one by one. So the first one is autoregulation. So even if our blood pressure is within the range of 80 to 180, during that time the renal blood flow and the GFR will remain constant. So to understand that, I'll draw a graph with the arterial pressure on the x-axis and the rate on y-axis in milliliters per minute. So see, this is our arterial pressure between 80 and 180. In this range, you can see that the renal blood flow is almost constant. What do we expect? If the blood pressure is more, what we expect is the renal blood flow will also be more, right? That is what we expect. But because of this auto-regulation, between the blood pressures of 80 and 180, the renal blood flow will remain constant. So there is something which is preventing the renal blood flow to increase. Now, not only renal blood flow, the GFR is also constant, or glomerular filtration is also constant. So this constancy between 80 to 180 millimeters of mercury is because of autoregulation. So it is independent of nervous system or hormones. Even if you denervate the kidneys, still this autoregulation will be there. So there are two mechanisms by which this is possible. The first one is a myogenic response, and second one is a tubulo-glomerular feedback. So we'll see each one by one. The concept is simple. So first is a myogenic mechanism. So this is our afferent arteriole, the glomerulus efferent, and you can also see that this is the ascending loop of Henle along with the juxtaglomerular apparatus. Now suppose we take a scenario wherein the BP is increasing. So what do we expect? We expect that there's going to be more blood flow, right? There's going to be increased blood flow through the afferent arterioles. So what will happen to the blood vessel wall? There is going to be a stretch, right? Now, once this stretch occurs, there is an automatic mechanism which ensures that the renal blood flow decreases. What is that? See, this stretch will act, the smooth muscles are being stretched on the walls of the arteriole. So, once the stretch occurs, there will be opening up of the stretch gated calcium channels, which in turn will allow entry of calcium. And this entry of calcium again will activate the voltage gated calcium channels because of the change in voltage, and this entry of calcium will cause contraction of the smooth muscles. So once if there is afferent arteriole constriction, what happens to the GFR? First of all, obviously the renal blood flow is going to decrease and the GFR is also going to decrease. So that is why in this case, even though there is an increased BP, the renal blood flow as well as the GFR will remain constant. Okay, so that is the myogenic mechanism. Now reverse happens if the BP falls. The stretch receptors will not be activated. There will not be any calcium. So arterial constriction will not be there. Okay. So the myogenic mechanism is, suppose there's an increase in arterial pressure, it will stretch the afferent arteriolar wall, which in turn will open the voltage gated calcium channels in the smooth muscle, which in turn will cause calcium influx, contraction of the afferent arterioles. So there will be increased resistance to the blood flow. So naturally the renal blood flow as well as the GFR will decrease. Okay, so that is the myogenic mechanism. Next, the tubulo-glomerular feedback. What is tubulo-glomerular feedback and how does this mechanism help to maintain the renal blood flow and GFR? So suppose here also there's an increased BP and there's increased renal blood flow. So the second mechanism is, we know that if there's a renal blood flow, usually there is going to be increased GFR, right? Now if there is increased GFR, that the amount of sodium and chloride that is coming to the distal limb or the thick ascending loop of Henle will be more, right? See, there is increased filtration. So naturally there will be increased solutes in the tubule. Now that will be sensed by our macular densa cells. See, we've got the macular densa cells which will sense this increased amount of solute load that is reaching the tubules. Then it will give information to the nearby juxtaglomerular cells by releasing the neurotransmitters ATP and adenosine. It will release these substances, and this in turn has two effects. First of all, it will act on the afferent arteriole to cause constriction, Okay, so that the renal blood flow can decrease and the GFR can decrease. Secondly, it will also act on the juxtaglomerular cells to decrease the amount of renin, so that again the BP can be brought to a lower level. So this is one mechanism. This is another mechanism by which the kidney or the nephron ensures that even if the BP is more, the renal blood flow and the GFR is normal. So if the BP is high, the renal blood flow and GFR will be ideally more. So there will be more sodium chloride delivery. But the macular densa cells, the sodium chloride in the tubular fluid, it will release ATP and adenosine, and these substances ATP and adenosine will bind on to specific receptors on the afferent arteriole called the A1 receptors and cause vasoconstriction, so that both can be brought to a normal level, RBF and GFR. Now this was a scenario in which there is increased BP. What if there is a BP decreased BP? Then how will the RBF and GFR be maintained? For that also we have a mechanism. So suppose there is a decreased renal blood flow. Suppose there was a volume loss and there is a BP fall and there is a decreased renal blood flow. Then obviously your GFR is going to decrease. So obviously the solute load is going to decrease. So there will be decreased sodium and chloride. Now that also will be sensed by the macula densa, and this time it is going to send the signal using another substances called nitric oxide and prostaglandins. Now this what they do is, first of all, because nitric oxide and prostaglandins are dilators, they cause afferent arteriolar dilatation so that more blood can enter the afferent arteriole. Now not only that, it will send signal to the juxtaglomerular cells asking them to increase the amount of renin release. So what will happen if renin is released? If renin is released, then renin angiotensin aldosterone system will be activated, especially that angiotensin. So this angiotensin will be released and that will act on our efferent arteriole to cause constriction. Now remember, what did I tell when there is efferent arteriolar constriction? Again, there is going to be increased glomerular filtration rate. So the glomerular filtration rate can be maintained at a high level. The renal blood flow also can be maintained at a high level. So that is how the system works if there is decreased renal blood flow. So if there is decreased BP, there is decreased RBF and GFR, decreased sodium chloride delivery. The macular densa cell sense the sodium chloride in the tubular fluid. It releases nitric oxide and prostaglandin, so afferent arteriole dilates. It also causes release of renin, which activates the renin angiotensin aldosterone system. Angiotensin 2 causes efferent arteriolar constriction and thereby restores the GFR. Okay, so this is the mechanism or the mechanism of autoregulation that is present in the kidneys. So of the three mechanisms, we have seen the first one, that is autoregulation. Next we'll see about the neural control. So we know that the nephron has got a rich sympathetic nervous supply, right? So the sympathetic nervous system, they release the neurotransmitter norepinephrine, which will bind on to the alpha 1 receptors that are present on the afferent and the efferent arteriole. Now the important point is, in fact, the efferent arteriole is more sensitive to this norepinephrine. So naturally, initially it is going to cause efferent arteriolar constriction. What will happen if there is efferent arterial constriction? There is going to be increased GFR, right? But if the concentration is more, then it will cause constriction of both afferent as well as efferent arteriole. In that case, there is going to be decreased renal blood flow and decreased GFR. Now, not only the afferent and the efferent arterioles, the renin, the juxtaglomerular cells also have got the receptors for norepinephrine, which are beta 1 receptors, which will stimulate renin release. Okay. So the primary action is if efferent arteriolar constriction, which is going to increase the GFR, and the secondary action is if the amount of stimulation is more, you're going to have an afferent arterial constriction, which leads to decreased GFR. So this is how the neural regulation would work. So sympathetic fibers, they act on the alpha 1 receptors. They cause vasoconstriction of the afferent and efferent arterioles. If there is moderate stimulus, mainly it is the efferent arteriole that is affected. But if there is strong stimulation, that can cause severe vasoconstriction. So there will be decreased renal blood flow and decreased GFR, and this functions mainly for conserving the fluid so that there is no fluid loss through the kidney. It occurs especially in cases of shock and hemorrhage. So this is important for acute blood pressure changes, so that the body can be protected against complications like shock and hemorrhage. Okay, so that was about neural regulation. So of the three, we've seen the neural regulation also. The last one is hormonal or paracrine control. So there are, as I said before, the action of vasoconstriction and vasodilation has got a huge effect on the renal blood flow as well as the glomerular filtration rate. So we've got some hormones or substances that act on the nephron and has got a constricting action as well as a dilating action. So we'll see what they are. So first of all, we'll see about the vasoconstrictors. The first and the most important one is the angiotensin 2. Now remember, the important point about angiotensin 2 is that it likes efferent arterioles more. So first of all, it will try to cause efferent arteriolar constriction, which first will cause an increase in GFR. It is only if when the angiotensin 2 level is really high, only then it will cause constriction of both afferent and efferent. Second is endothelin. This is also a very potent vasoconstrictor, again released in case of kidney injury. And then we've got a catecholamines like norepinephrine and epinephrine, which is usually present during sympathetic activation, the function of or the mechanism of which we've just seen. So the three important vasoconstrictors are angiotensin 2, endothelin, and catecholamines. What about vasodilators? I think we've already discussed them, right? Prostaglandins, they are vasodilating, they dilate the afferent arteriole and thereby counteract the effect of the angiotensin 2. Then we've seen about nitric oxide, okay? They cause basal vasodilation, protects against excessive constriction. And finally, we've got the atrial natriuretic peptide, which dilates the afferent arteriole and constricts the efferent arteriole so that there will be increased GFR. So these are the three important vasodilators: prostaglandins, nitric oxide, as well as atrial natriuretic peptide. So thus we have seen the three important mechanism by which the renal blood flow is regulated. So why do we have three? So basically by autoregulation, it is short-term moment-to-moment stability is given by autoregulation. The neural control adjusts the blood flow during stress, exercise, hemorrhage. When you have a short-term problem, it is the neural control that comes in. And the fine tune of it all is brought about by hormones and paracrines, and it has long-term effects. They fine tune the balance, protect the kidney, and give long-term effects. So autoregulation, moment-wise, neural control for emergencies, hormones for long-term. So they all act together to maintain a stable renal blood flow and GFR. So finally, let's just discuss some important clinical aspects. Okay, so there are some drugs which has the risk of affecting the kidneys and which is protective. So we'll see each by one by one. We know that NSAIDs, okay, we say NSAIDs are not good for kidney patients. Why? Because they block the prostaglandin synthesis, thereby decrease the afferent arteriolar dilatation, thereby decrease the renal blood flow, and thereby there's a high risk of acute kidney injury. That is why we say that kidney patients should not be given NSAIDs, and long-term use of NSAIDs should be avoided because it can cause kidney injury. Secondly, we have ACE inhibitors. Now what this does is it blocks angiotensin 2. Okay, ACE is angiotensin converting enzyme. So it blocks, when you have an ACE inhibitor, it will block the formation of angiotensin 2. So blocks it and thereby cause blockage of, it will cause efferent arterial dilatation. What will happen if the efferent arteriole is dilated? We will have decreased GFR. So again, this cannot be used in renal failure patients. And in renal ischemia, actually endothelin release, there will be endothelin release and there will be severe vasoconstriction, because we said that endothelin is a strong vasoconstrictor. So these are some clinical aspects related to it, of which NSAIDs and ACE inhibitors are very important. What is the full form of NSAIDs? I'm just mentioning it because you might not be familiar with that. It is non-steroidal anti-inflammatory drugs. Okay. So that was about the clinical aspects. So in a nutshell, in regulation of renal blood flow, we've seen about autoregulation, in which we mentioned in detail about the myogenic response as well as the tubular-glomerular feedback. Then we talked about neural control, in which we talked how the sympathetic system acts on the nephron. And finally, we've seen about the hormonal and the paracrine control, and finished off with some clinical aspects. So I hope this video was useful for you. Thank you.